Welcome to Cancer Newsline, your source for news on cancer research, diagnosis, treatment, and prevention. I'm your host, Lisa Garvin. Dr. Litton, how common is it to find a woman diagnosed with cancer who is also pregnant?
Well, I think that we used to think this was exceptionally rare, but as data is coming out that women can receive treatment during pregnancy, we are noticing that more women are seeking treatment. In addition, as women are now delaying childbearing into 30s and even 40s now with reproductive endocrinology, we are seeing trends of this being an increasing phenomenon.
Is there a typical type of cancer that these women have, or is it all across the spectrum?
Well, it's really all across the spectrum. The most common one that we see is breast, but other common ones can be thyroid, cervical, melanoma. We can even see some of the hematologic malignancies. Really, any cancer that can happen to someone in that age group, it can happen during pregnancy.
So I think in the past, some women have chosen to delay treatment because of myriad fears about treatment. Is it a good idea to delay treatment until the baby is born?
Well, I think it depends on the type of cancer identified and where you are in the pregnancy. Sometimes you're close enough to delivery that we do recommend you move forward with delivery and we treat after. But in the case of breast cancer, we know that if we give the same treatment we would give to our non-pregnant women, that they do just as well as non-pregnant breast cancer patients. The caveats is that we start chemotherapy only after the first trimester when all the organs are formed. So we give it in the second and third trimester. We've shown from our research here, as well as our colleagues in Europe, that surgery options can all be given safely, both lumpectomies as well as mastectomies, but we do want to delay radiation until after delivery. And the other caveat is the recent development of anti-HER2 antibodies. We do show that when we give that during pregnancy, it can cause low fluid around the baby and even some kidney issues in the baby. So we delay that until after delivery whenever possible. We know that when we delay treatment for cancer, we do decrease survival and often many outcomes. And so we do want to start therapy at least after the first trimester. I think that a lot of my patients come to me with their bigger concern, not only just for themselves, but potential effects on the fetus. And from our research, as well as collaborating researchers such as Elise Cardonic at Banner Health and our colleagues in Europe, we really have shown that when chemotherapy is given in the second and third trimester, we have not seen significant effects or increased rate of birth defects over what we see in the average population. So we want to make sure we treat the mom, and we want to make sure that we follow these children. But so far, we really haven't identified any significant new side effect that we need to watch for at this point.
How do you pair with the patient's OB/GYN and collaborate care?
So we have very good relationships with many of the maternal fetal medicine doctors here in Houston. And what I ask for them is to see before each and every chemotherapy to do fetal ultrasounds to look for the fluid around the baby, to look at the growth, to look at the cord. And often the mom will go have that ultrasound, make sure everything is okay, and then they'll come across the street to see us and we'll give that dose of chemo.
What would be your advice for women who are pregnant, diagnosed with cancer, and scared? What can you tell them?
I think that the first thing you need to know is that you don't need to make a decision right away. You have time to gain information, to get a second opinion, and to seek out someone who has that expertise, both in the maternal fetal medicine as well as surgeon and medical oncologist.
Thank you, Dr. Litton.
Thank you.
For more information, visit mdanderson.org. Thank you for listening to Cancer Newsline. Tune in for the next episode in our series.